Hello, good morning. I'd like to thank the Resuscitation Council and Catherine Baldock for inviting me to present on behalf of NHS Forth Valley. We started discussing this last year when I met with Juliet Spiller, actually at a DNA CPR Education Day, and we decided that being quite a compact health board in central Scotland, we would be well equipped to move forward with a pilot of ReSPECT. So we are a small, relatively small health board. We have a population of approximately 300,000 people, and we are surrounded by a number of other health boards, which is obviously important at the points of transitions of care and communicating across health boards the information that you hold. In terms of the context of ReSPECT, from a Scottish point of view, we have a well-established DNA CPR policy across Scotland. We all use the same form. And we decided to look at how many people across our organisation actually had a DNA CPR decision. So we performed a census, so to speak, last year in March 2017 across 900 beds. That comprised acute, community, learning disability and mental health, and our point prevalence of DNA CPR decisions were 32%. 63% in the community hospitals, but going up to 90 to 100% in some community hospitals with frail elderly who'd been in there for some time. So it gives you a sort of the context and the potential scope for a move to ReSPECT. We later audited how we were doing with the change in the policy from 2016, where there was a move to improved communication, and 80% of our decisions were being communicated with patients or relatives. The majority of such decisions, as one might expect, were within the medical directorate. Mr. and Mrs. Daniels illustrated the sort of visibility of DNA CPR decisions, and again, this is something that I came across within our organisation. So we worked with our team, the EDMS team, to improve the sort of electronic visibility. People were coming back into hospital where perhaps families were having to have the conversation again, where the decisions were not perhaps communicated well across transitions. So that's the background. There's a landmark paper that you may be familiar with, Realistic Medicine, our CMO, Catherine Calderwood, which really embodies the ethos of ReSPECT, and that looking at shared decision making and a more person-centred approach. So a time for change. Before we embarked on the ReSPECT pilot, we took a snapshot of one of the pilot ward areas, and the prevalence at that point of DNA CPR decision making was 60%, but actually knowing the escalation plan or emergency care plan was done less well, so approximately just under 10%. So really the aims of our pilot were for matters of patient safety, we had to stick with DNA CPR alongside ReSPECT, as it was a small pilot. We're looking to increase emergency care planning, making sure that the information was up to date, useful, really easy to access, but also having earlier conversations which were person-centred and shared. And that brought us on to, it would be useful to have feedback from the patients and relatives that had gone through the experience. So it was a 4-month project, started in November, some months of planning leading up to it. We looked at 4 areas: an acute elderly care ward, elderly mental health ward, day hospice and community ACP team, but the majority were performing the acute elderly care ward. We linked in with the systems that we'd improved already, so we utilised what we had. We had a generic email address that forms could be scanned and sent to, and then would be uploaded so that we were visible and easy to see by any healthcare professional, but not perfect system, but I'll come on to that later. We looked at process and outcome measures, but what became really important was it was about the qualitative data that we were collecting, what people thought about the process. And we embarked on some education for the wider hospital and focusing on the pilot area. We decided to take a targeted approach as it was mainly hospital-based, and given the finite amount of time that we all had, we wanted to make sure that we were having conversations with people that we felt we could add most value. This has been adapted from the BMG practice pointers. In our main ward, where we collected the quantitative data, about 70% of people screened positive. The majority of these people had complex and long-term conditions. Recurrent admissions was not a big flag, and in fact, about half of the people had not been in hospital in the last 6 months, and people who were at risk of deterioration or had life-limiting conditions. I was talking about the visibility of the form. We utilised our IT systems to make sure it was easy to see on one of our electronic systems. It's easier to actually look at your quantitative data. When we did this, we could pull CHI numbers, we could get numbers easier. Our EDMS team would generate numbers monthly. So this was us. We started to upload documents in November 2016, so this just shows the trend of increasing uploading of documents. Unsurprisingly, patients were older, given the pilot wards that we looked at. And we also just looked at what sort of trajectory were these patients on. It was quite an uneven spread. Other was often patients who had come in with sepsis or may have had a neurodegenerative disorder. I can't go through all of our results today, but I'll focus on the main findings that we came back with. That 70% of people were able to engage in their priorities. About a quarter of people involved in the project lacked mental capacity. Our results are actually very similar to Catherine's results, and about half of people felt prioritising comfort was more important, and many picked the middle line of in between. We actually analysed 100 forms. So the pilot project, we completed 76 forms. We've actually now completed 160. We've been through the process with 160 plus people and their families. Again, the split is quite similar. The majority of people were not for CPR. Again, one of our meetings came up about the jargon about ward level. What does that mean when you go into primary care? Some of the recommendations are very specific, depending on the pathology. Non-oral nutrition for patients often who might have a neurodegenerative disease, where it could be predicted that they may develop a swallowing problem. So what happened? The process was someone came to that area, they were screened. We would then offer them to complete a questionnaire, and we were very appreciative for the time that the patients and their families took to complete the questionnaires, given that many of them were recovering from an illness or had a life-limiting condition. The feedback that we had was overwhelmingly positive, that people felt very involved, they were asked about what mattered to them, that they were respected, and they were treated as a whole person. So the overall rating for people that had actually been through the process, they felt it was excellent. And this is some of the feedback that we received from patients themselves or their family. So again, some of the words that jump out have been mentioned before. Open, I heard Daniel's again talking about open and honest communication, having a sense of control, being person-centred, and felt that this should be rolled out nationally. We also engaged with carer groups, so these were people who had not been through the actual process, but either put themselves in the position of being a patient or one of their relatives, and again, similarly, we had excellent feedback from these groups. Some of the feedback is quite interesting. Some felt the sliding scale was a bit vague and they would have preferred it to have been broken up more. And certainly a lot of themes coming out about end of life and decisions around having some control over that point. And it certainly is a vehicle for a conversation. Additionally, people were very interested in using ReSPECT, so when they heard about it, they wanted to use it out with the pilot. So, for example, in primary care, GP groups doing comprehensive geriatric assessments felt this was a natural part of that, and that actually someone says, I want to prioritise comfort. Well, you know, you're still on 12 medications, let's have a look at that, and we can make this a comprehensive review. In terms of the challenges, because it was a pilot, it did take longer. We had to explain it was a new process, and we wanted to receive feedback, so it did take some time, but also timing was important, particularly as we were electronically uploading the forms. We didn't want to do it too early in the patient's journey. Many were coming in for diagnostics, and we did not have all the information about them at that point. Perhaps they were delirious. We wanted to have the conversation when they had capacity. So the next stage is that we have presented it to our governance teams and clinical outcomes groups, and we're planning to roll it out more widely across the organisation. For the purposes of the pilot, it was only in adults, but for the moment. We hope to do some public engagement, and again, how do you pitch that when you need your staff resource to be able to do that? So it's trying to get that balance. We want to do a staff evaluation about the education, about how they felt about it, some of the feedback about what the quality of the information that's held in the forms. We're revising our electronic systems, we're moving paper light, and so we have to make sure that ReSPECT is here to stay in our health board, so we're encompassing that within our electronic systems. It's about raising the profile in Scotland. If we go solely with ReSPECT, then we would be going against the national policy, but we're showing its worth. So we're looking at longer term outcome data as well, and looking at improving the education. So I just want to thank the quality improvement team at NHS Forth Valley and the group that supported this. Thank you.